Now, this video is going to be focusing on some of the supraventricular tachycardias because we've already discussed atrial fibrillation and atrial flutter. Let's talk about premature atrial contractions. So you've got these arising from either the atria itself, the pulmonary veins, or the AV node. So premature beats are of three types. They can be either of atrial in origin, they can be premature junctional contractions, or they can be premature ventricular contractions. A couplet is going to be two PACs together or two PVCs together. An atrial bigeminy is a phenomena in which every normal sinus beat is followed by a premature atrial contraction, and that keeps going on throughout the rhythm strip. More than or equal to 3 PACs will constitute a supraventricular tachycardia. This becomes either sustained or non-sustained. So this basically depends on the time duration. So a sustained SVT is going to last more than 30 seconds, and a non-sustained SVT is going to last less than 30 seconds. So we first talk about atrial tachycardia and a multifocal atrial tachycardia because these are quite common. So an atrial tachycardia comes from the atria but not from the sinoatrial node. It is from an ectopic focus. It is usually monofocal in origin, and it has a morphology of P wave that is not quite similar to that of a normal sinus P wave. In a multifocal atrial tachycardia, there is more than or equal to 3 foci in the atria that are propagating the tachycardia. So you have 3 different kinds of morphologies of the P wave, and the rate is usually more than 100 beats per minute. Because there are varying focus of P waves, you can have varying PR intervals in a multifocal atrial tachycardia as well. So that right there is an example of an atrial tachycardia. Remember that an atrial tachycardia will always end with a QRS complex. And then we take a look at an example of multifocal atrial tachycardia. So you can see that there are 3 different shapes of P wave. They can have more or less a different PR interval as well. So a PAC initiates a supraventricular tachycardia, and this is further divided into a atrioventricular re-entrant tachycardia. This is mediated by a bypass tract. An atrioventricular nodal re-entrant tachycardia, and as the name suggests, this is dependent on the AV node for its propagation. And then the third one we've already discussed, which is a atrial tachycardia. We're going to be discussing mostly the AV nodal and the AV re-entrant tachycardias. We're going to draw a bit of a diagram over here which shows the AV node with a bundle of His in the right and left bundle branch blocks here. So we're going to divide it. The atria will be above and the ventricles below. That is the sinoatrial node. That is the AV node. You've got the bundle of His, the right bundle and the left bundle. We're going to copy that image multiple times so we can understand all types of supraventricular arrhythmias. So a normal sinus rhythm will be a beat coming from the sinoatrial node, going down through the AV node and going into the right and left bundle branch, propagating towards the ventricles. An ectopic atrial tachycardia, which is also an atrial tachycardia, will arise from anywhere between the atria and then go towards the AV node and then carry on as normal. A multifocal atrial tachycardia is going to come from multiple foci in the atria, usually more than 3. They all come towards the AV node and then propagate as normal. The next example is that of atrial flutter or fibrillation. This has already been discussed in one of the previous videos. So in a flutter, you've got a very regular re-entrant, a macro re-entrant circuit inside the atria, while in fibrillation, you've got a haphazard current, both of them going towards the AV node. So in a atrioventricular nodal re-entrant tachycardia, which depends on the AV node for its propagation, what we'll do is we'll zoom in on the AV node, and we have to talk about the anatomy of the AV node a little bit as well. So in a normal situation, what tends to happen is that a beat comes down from the atria, travels down the fast pathway first, and then goes towards the ventricles. The same beat is carried down via the slow pathway as well. But what tends to happen is that the fast pathway's beat goes up via the slow pathway and blocks that beat at the same time. Because a PAC is generated during the time in which the fast pathway is in refractory period, it is not able to propagate the current down towards the ventricles. Now, at the same time, that PAC is conducted down via the slow pathway and it goes towards the ventricles. And then this beat is conducted upwards via the fast pathway. This time, the fast pathway is not in refractory period. And because of that cycle, what tends to happen is that the beat is propagated down via the slow pathway, goes towards the ventricle, and then it is propagated up via the fast pathway. And so a circuit is created inside the AV node which enables this kind of dysrhythmia. The next one is a junctional ectopic tachycardia. So fairly straightforward. The junction is responsible for maintaining this tachycardia. The next one is the atrioventricular re-entrant tachycardia. We already spoke about the fact that this is bypass tract mediated. So what we'll do is we'll draw a concealed or a revealed bypass tract over here. Now the beat comes down via the AV node and goes up via the bypass tract. Another type is a permanent junctional reciprocating tachycardia. This type of tachycardia will also be mediated with the help of a bypass tract. So a beat comes down via the AV nodes and then goes up via the bypass tract. But this usually happens in neonates and there is no pre-excitation seen on the ECG. Anterograde conduction, as we saw in this example of AV nodal re-entrant tachycardia, was happening via the slow pathway, and retrograde conduction was via the fast pathway. This is the reason why this is called a slow-fast pathway. 80 to 90% of the time, this is the type of AV nodal re-entrant tachycardia we see on ECGs. So what do we actually see on the ECG? The atria and the ventricles depolarize almost simultaneously in this kind of dysrhythmia. So the P waves are actually buried within the Cuirass complex, and it is very difficult to detect them. Very rarely what we see is that the atria depolarize after the QRS complex, and they depolarize in a retrograde manner. So what you can see is that you can see a P wave that is happening just after the QRS complex and in a retrograde manner, so an inverted P wave. And this is most commonly found in the inferior leads, the 2-3 AVF, and it is referred to as a pseudo S wave. In V1, at the same time, you will be able to see a pseudo R wave because of this retrograde conduction into the atria. A fast, slow type of AVNRT happens when anterograde conduction is via the fast pathway and the retrograde conduction is via the slow pathway in the AV node. This can also happen with a bystander concealed pathway. Another example is that of a permanent junctional reciprocating tachycardia that we discussed above. That usually happens in neonates, and there is no pre-excitation seen on the normal ECG. So what you'll see on the ECG is a tachycardic rhythm. It will be regular. There will be no respiratory variability with this. The rates are usually between 140 to 280 beats per minute. Check if there is any P wave, if it is absent, if it is present. You can also look for P waves after the QRS complex as well. Look for the presence of flutter waves. Look for the presence of fibrillatory waves. As discussed, the pseudo R wave and the pseudo S wave. That's all for today. Let me know in the comments section if this was helpful or not. Don't forget to like, share, and subscribe to the channel. And have a good day.